Benvenute, welcome. 欢迎大家来到 VWin 第二次国际晚会。
Welcome to the second VWin webinar. So in front of us, the two architectures are the Italian pavilion and Chinese pavilion were to be shown in the next World Expo. It means that China is reaching out to the world and the world is welcoming China. So very good morning, dear colleagues. My name is Willie Chi. I'm more than honored to have been representing VWin and the Chinese Association for Phlebology. So this official language would be Chinese, with English and Spanish simultaneous interpreting. For any of you who would like to ask questions, please type in the question on the QA chat, and we will raise the question with the highest ranking. For those who want it to be part of our medical education, please scan the QR code. If you want to know more information about our organization, please come to the website of our organization. And the first webinar was held on the 14th of November. Therefore, we'd like to thank all of you for your contribution. This is the second VWin China webinar. And we'd like to share our gratitude to Mr. Wang Shenming, Mr. Chen Zhong, and Professor Bottini and Professor Giannettini, and also among many other experts from home and abroad. Last but not least, I'd like to thank our sponsors, including Alpha Sigma, who is also the main sponsor for our vascular webinar, and BD, Maddie, Phillips, and Sigvarius Group. Thank you all. And we'd like to give the floor to the former first president of Sun Yat-sen Hospital, Mr. Wang Shenming, to give an opening remarks. Let's welcome.
Dear Professor Sergio, dear Professor Bottini, dear Professor Caprini, dear 亲爱尊敬的季教授，尊敬的陈忠教授
Distinguished Professor Ji, Professor Chen Zhong, Professor Li Yiqing, and dear professors, experts and colleagues, good morning. Great thank to VWin Foundation, Professor Sergio Bottini, and Professor Ji to host this VWin webinar. Last month, we held the very first VWin China session, and this is the second session. On behalf of the International Venous Association's China branch, to share our heartfelt thanks to the organizers, and also congratulations to VWin China. Today, we are more than honored to have invited Professor Caprini to share with us his insights, the VTE prevention and the global insights under COVID-19. We believe that we are all quite acquainted with Professor Caprini. The hospitalized VTE prevention system, actually, we are using the Caprini score developed by Professor Caprini. So today, we are very honored to have invited Professor Caprini, and also Professor Chen Zhong will be representing Chinese vascular surgery to share with us the Chinese guidelines of the CVD. At the same time, Professor Li Yiqing will give us a presentation about the COVID-19 VTE treatment. We know that Professor Li Yiqing is working at the forefront of the COVID-19 prevention and treatment in Wuhan, China. So he has been very well positioned to talk about that topic. And also joining us will be other experts talking about the venous disease prevention and treatment issues. We believe that We Win China session will definitely give us a brilliant insight from home and abroad and deepen our international exchanges that will in turn contribute to the prevention of the disease, and wish this event a complete success. Thank you. Thank you, Mr. Wang, for your opening remarks. And we'd like to give the floor to the second speaker from Buenos Aires University, vascular surgeon, and also the vice president of the association, my good friend, Professor Bottini, who will give us a brief opening remarks.
Thank you, Willie. It is my true honor to be part of this special event in which we'll enjoy presentation by the most important international leaders, a session which I know will be extraordinary and of great interest. A real honor to me to open the session today. Please, Latin American people, remember to select the Spanish channel. To the Western world, I wish the best end of the year. Always taking into account everything bad will soon be over. Happy holidays. Thank you.
好的，我们谢谢布提尼教授给我们的发言。
for your speech.
是意
Now
大利
let's give the floor to
外科教授，也是国际静脉
Professor Giussini from University of Ferrara and the youngest vice president of International Venous Society. Let's welcome Professor Giussini.
Thank you so much, Professor Chi, and thank you so much from the bottom of my heart to all the great professionals involved today, from China in particular, and also from the world, of course. Today we will enjoy an educational walk with the true giants of the field, again, both from China and the world. So we deeply thank all the ones who have been walking with us in the previous time. So please advance your slide, Willie. In the teamwork we have developed with the publication on global guidelines, similarities and controversies, we look forward for the present action that is working together on no fake news in medical communication. So please advance, Willie, because indeed this is the core project related to these webinars. Please advance, Willie. That is indeed a Delphi consensus that is involving 70 societies from all around the world. And again, I deeply thank also the Expo Dubai that is giving us the chance of connecting experts to properly inform patients. So I wish you all a great webinar, and I deeply thank the giants who are allowing us to walk on their shoulders today.
好的，我们感谢Giussini 教授给我们
We
的
thank Professor Giussini for your speech.
第一位的讲者是
The first speaker today
国际权威
is an international expert
院长
China is very familiar with.
介绍了一下
Just now, Professor Wang briefly introduced this professor.
他是
He's a household name in China. This is
教授，
Professor Caprini from University of Chicago.
传您的 PPT， 谢谢。
Professor Caprini, please share your screen. Professor Caprini.
Thank you very much. It's a great pleasure to see all of my wonderful friends.
Dr. Caprini, you have to be in the English channel, please. Please put your English channel.
Thank you very much indeed. It's a great pleasure to be among all of you and to see all of my wonderful friends, especially my Chinese friends that have done so much to develop the Caprini score throughout China, and it is a great honor. Should I do my presentation now? Or just say hello?
Yes, sir, please.
You're muted.
Yes, sir, please, doctor. Go ahead and share your screen.
您要开麦。
Well, it's a great honor again to be a part of this and to have so many wonderful friends from around the world and to be able to present these data. These are my disclosures, and it is it is not a surprise that I'm going to talk about the Caprini score, and we favor that because it's the most comprehensive history and physical available around the world with over 40 risk factors. And as you know, as the number of risk factors goes up, the incidence of DVT goes up. And and in addition to that, each of the risk factors is associated with a strength. And some risk factors are very weak, such as bed rest and hormones, and some are very strong, like cancer of the pancreas and past history of thrombosis. So it's the number of risk factors plus the power of each risk factor that are put together in a statistical calculation and resulting in a score. And the score is a nonlinear association with DVT. So as the score goes up, the incidence of DVT goes up. And there's different populations, and the set points are very different for these populations. This is a population in general surgery. So we know that capturing all 40 elements in the score is a time-consuming process, and the collection is facilitated by having the patient complete a preliminary patient-friendly form in advance of elective surgery, ideally with the help of family members. Patient's family should assist in completing the form at the time of hospitalization. And the physician or other healthcare provider responsible for admitting history and physical should review the form and create a final initial document. I'm very proud of the Chinese because I believe they're, as we speak, putting together a patient-friendly app that will enable people to do this on their phones or on their electronic devices and be able to easily score themselves and then present it to their doctor. This score is in a variety of languages, and there's two very important things that make this score unique in all the world. The first is we track the current use of birth control pills, but also obstetrical misadventures. These include stillborn infants, spontaneous abortions, premature birth with toxemia, or baby born smaller than appropriate weight, a low growth rate, placental retardation. These clinical events may harbor in the patient an antiphospholipid antibody syndrome, lupus anticoagulant, beta-2 glycoprotein, or antiphospholipid antibody syndrome. These three things, they may be there silently for life. And if one does not take a good history, one is not tipped off to those people that could have that problem. In addition to that, another thing that is unique about this, and I believe only the British system also captures it. You know, some of the risk assessments say history of thrombophilia, but that's meaningless. First of all, in Asia, thrombophilia isn't that common. And also, most of the clotting defects in families, we don't have a marker that we can measure. And if there are markers, they're very expensive. So family history of thrombosis in all three generations is very important to document. And that's a very important feature of this score. The other thing about this score is that this is a dynamic instrument and has to be revised as a reoperation may occur, infection central lines, cancer diagnosed during the stay, and an updated score will often result in a change of thrombosis prophylaxis, including post-discharge anticoagulant prophylaxis. We know people that have low scores and are admitted to the hospital don't benefit from prophylaxis, but if they develop these problems during their hospitalization, then they become candidates. We also know that, and we came up with this classification, and the question was asked, why did we come up with this? Well, we thought that coronavirus is such a serious disorder, and it's so thrombogenic that we better add some risk factors for that. And Kirill Lobostov has pioneered this in Russia and taken a look at a series of patients and followed them for 6 months. And what we found at the conclusion was, although this score could be used, We don't really need it. All we need to do is use the standard Caprini score and give 1 point for an infection, which is the coronavirus, symptomatic or asymptomatic, and then 3 points for an elevated D-dimer, which we already do, so that the regular Caprini score will suffice for these problems. So what do we know so far? Well, of course, we know that this is a viral-induced inflammation, which triggers a cytokine storm causing tissue factor release, thrombin generation, fibrin formation to coat the virus and prevent spread. That's a great mechanism. The unfortunate side effect is thrombosis. And the activation of thrombosis with hypercoagulability results in DVT, pulmonary embolus, but also pulmonary thrombosis. Stroke or arterial thrombosis may occur, and microthrombosis may occur in the lungs, liver, kidney, anywhere in the body. Fibrinolysis may occur to dissolve the thrombin, but the fibrinolytic mechanism may get overwhelmed due to the amount of thrombin being generated, so you might have a reduced fibrinolysis, which then leads to more clotting. There's also a DIC picture, DIC-like picture, which can result in thrombosis and is characterized by changes in the PT, PTT, and platelet count. But this is really very important, and people really haven't gotten their arms around this yet. And that is that this virus goes back to what we learned in the 70s from Oscar Ratnoff, a famous hematologist. And Oscar Ratnoff discovered factor 12 in his patient John Hageman, the contact activating factor. And what he found was that as Hageman factor is activated, it activates the platelets with platelet plugs and thrombosis. It causes coagulation, prothrombin to thrombin, fibrinogen to fibrin, and thrombosis. It also stimulates the fibrinolysis pathway. But most importantly, it also triggers inflammation, inducing elaboration of interleukin 1, 6, and cytokines. And this is the inflammatory pathway. But not only that, it also activates the kinin pathway with bradykinins, slowing of the heart, vasodilatation, increased vascular permeability with PF-DIL. And as a result of that, there is also activation going back to complement of phagocytosis binding the pathogens and cell membrane damage, bacteria and virus. Now, we all knew this in the 70s. And we knew this occurred when factor 12 was activated. But what is not really even fully realized yet, and maybe it's beginning to be, is that COVID-19 is the tangled hemostatic web on steroids. And what happens in this process is so complex. And of course, anticoagulation alone isn't the answer. You need a cocktail of antiplatelets, antifibrinolytics, anti-inflammatory drugs, and antikinins, and so forth to block antigen antibody-like responses. That's almost an impossible task. And so we just have to remember that anticoagulation alone is not the total answer. What happens with COVID-19 is that these viruses are like spikes, and they pierce the endothelial cells all over the body. And they have a predilection here for the beautiful endothelial alveolar interface in the lungs. And that's what causes the vast majority of changes in the lungs, including pulmonary thrombosis. Pulmonary hemorrhages can occur as well. And these respiratory difficulties are, of course, associated with an increased risk of death and so forth. Now, a while ago, we put out these postulates that all patients should receive heparin or low molecular weight heparin prophylaxis due to the high risk of thrombotic complications, including microvascular thrombosis. And this was gradually adopted by people. In the beginning, they weren't even using the regular dose of thrombosis prophylaxis. But what we really need to understand is we can't forget everything we've learned up to this point before the COVID-19 pandemic. We know that people that have elevated scores, elevated BMIs, congestive heart failure, myocardial infarctions, COPD, past history of thrombosis, family history of thrombosis, they'll break through on standard prophylaxis. You need to consider doubling the dose of prophylaxis in those patients. And we felt that, especially in the COVID population, this was extremely important to give a dose of double the prophylactic dose with these comorbidities. Now, what's really interesting is that the authorities, many of them, have not bought into this because they don't have prospective randomized trials. But what I found interesting is there's a recent article from New Orleans and 6,000 patients who had prophylactic doses of anticoagulation. Breakthrough thrombosis occurred in 50% of the patients. Yet the conclusion of the article was still, we still stick to the idea of prophylactic anticoagulation without doubling the dose. So gradually, I think we're going to see this change. I just reviewed an article today where it did show in a small group of patients that as you escalate the dose, the incidence of death goes down as well as DVT and PE. Now, we also recommend rescoring at discharge. This is absolutely critical. We go back in history, the Riete database, and we knew in 2008 that 55% of people who got their clots got them after they left the hospital and they were stopped from anticoagulation. And overall, 3/4 of the patients got clots. Now, don't get this confused. This doesn't mean that 75% of medical patients, when they go home, get a clot. No, no, no. This means that patients who are at high risk and went home and developed clots, that those clots manifested themselves not during the hospitalization, but afterwards, and not during anticoagulation, but afterwards. Now, what's happened since then? Well, we have more supporting data in both 2017 and by the same authors in 2020 just accepted that this picture hasn't changed. But don't forget, what happens with COVID-19? This introduces a whole additional level of complexity into this process. And those that say that there's a few reports out that show that outpatient prophylaxis after COVID-19 in patients who survived really hasn't shown that high an incidence. It has to be stratified according to the risk of the patient. It's not all patients, it's high-risk patients. So we know that we have some agents like Betrixaban and Rivaroxaban for both in-hospital and extended prophylaxis in high-risk medically ill patients. And we know that that affects more than 1/4 of the population. And again, here, other studies have shown that most of these people get their clots when they go home from the hospital. And yet, less than 4% of patients are sent home on prophylaxis. We feel that symptomatic venous thromboembolism, since it doubles within the first 3 weeks, and there's a 5-fold increase in PE events within 45 days, people who are at high risk should get ongoing prophylaxis. And there's, as you know, the trials are out there, ADOPT, Magellan, Mariner, APEX. And this goes beyond the Caprini score. This goes scoring of the patients. If your hospital uses the Padua score, if they use the improved score with or without the D-dimer, or whatever score you're using, all of these scores, as my friend Alan Davies said once, Joe, it's not the toy you're using, it's using a toy. Using a risk assessment to assess patients when they go home and making sure that they're protected, because COVID-19 magnifies all of these statistics. So in conclusion, it's important to perform thrombosis risk assessment using your favorite tool, understand the widespread involvement of the vasculature. Pulmonary thrombosis and alveolar endothelial damage are prominent features of this disease. Arterial or venous thrombosis can occur anywhere. Tailoring the intensity of anticoagulation is the key to success. Perform ultrasound scanning for specific indications only. It's very important. And post-discharge prophylaxis is required for most patients. So I'm sorry to rush through this. Time is limited. I thank you for your attention. And I am again indebted for all of the efforts all over China to help in this regard and help lower the incidence of the #1 fatal cause of death after surgery or hospitalization, that is pulmonary embolism, especially during this era of COVID-19. Thank you very much for your attention.
谢谢我们 Caprini 教授精彩的演讲。
Thank you, Professor Caprini, for your excellent presentation. We know that Caprini score has been used in the thrombosis, and especially during COVID-19 induced thrombosis, which is very important. And next session, we'd like to invite experts to ask questions. The first expert is from international, from Porto University, Portugal, the vascular surgeon and international angiology editor, Professor Messina. Because Professor Messina is living in Portugal, so it's midnight at this time. Therefore, he has recorded a video to ask the question towards Professor Caprini. And now I'd like to shift to English channel so that all of us can have a better hearing of the video.
Thank you for this kind invitation to participate in this live educational event. It is for me a pleasure and an honor. Thank you to Professor Joe Caprini for his outstanding presentation, as usual, on an overview on thrombosis risk assessment in this COVID-19 pandemic era. I have two questions. One is related to the location of thrombus. Do we have data about this issue? In these patients, the thrombus are located in the same usual sites or have unusual sites? And second question, as Professor Caprini mentioned in his presentation, anticoagulation alone, it is not the answer, but is part of the answer. And being part of the answer, do we have reliable data about the efficacy and safety profile of the different DOACs in these patients that we have to manage with deep venous thrombosis? Thank you again for this kind of invitation. Thank you.
Thank you very much indeed for those excellent questions. Regarding the first question, COVID-19 is unique. Thrombosis can occur anywhere in the body that there is a blood vessel, because as I said before, the COVID-19 virus are like spikes and they get into the endothelial cells and damage it. And then the inflammatory cytokine system starts. And as a result of that, the endothelium is damaged and you can have a clot anywhere in the body. We've seen some graphic illustrations of that from Professor Ramacati in arterial thrombosis from South America. And we've seen that organ insufficiency is also common. And as a result of that, you can have clots anywhere, and clots in unusual locations. Clots in the mesenteric veins, portal veins, and other splanchnic veins. That's all possible. So that we have to be prepared for anything, anywhere, as far as the thrombosis occurs. And then just before we get on to the second question, low molecular weight heparin is the standby and the staple for anticoagulation prophylaxis. And what I think that we need to do is that we need to escalate that dose according to the severity of the patient, keeping in mind a balance between that and bleeding problems. Most series have not shown high incidence of bleeding problems. And most of those problems are associated with patients who have kidney failure or patients who are on extracorporeal membrane oxygenation therapy. So that those are two of the areas that you have to be careful about. That having been said, it's very important that we tailor the dose to the patient. Now, as far as the direct oral anticoagulants goes, there are too many unknowns and inconsistencies and potential interactions with the DOACs to safely use them during hospitalization, especially when we're talking about some of the antiviral medications that are needed to be used during hospitalization in these patients. And as you know, with low molecular weight heparin, you can do a 10A assay and have some idea of where you stand at all times. And especially in the critical issues, you have that guide. And one more thing I'd like to share with you is what I call my secret weapon in 43 years of practice. And that is that in patients who were borderline or at high risk of bleeding, and you knew you need to try to give them some anticoagulation, but you also knew that you needed to prevent bleeding, I start a heparin drip. Started at a low dose. And that heparin drip, if the patient starts to bleed or has an untoward event, or in the case of CNS symptoms, starts to get some more symptoms, turn it off. If not, escalate the dose until you get the desired effect to prevent thrombosis. So thank you very much for those questions. Now, all of that having been said, once the patient goes home, perfect opportunity, as long as they continue not to be on antiviral medicines, to go ahead and use the direct oral anticoagulants. And particularly, we have good data for rivaroxaban in that regard. Thank you again for your question. Very, very fine questions.
好，我们谢谢 Caprini 教授精彩
Thank you,
的。
Professor Caprini, for your excellent answer. And our next speaker will be from China, from Beijing Tsinghua Hospital.
外科主任
The Director of Vascular Surgeon, Professor Li Lei, please open your mic.
谢谢。
听得到吗？听得到
Can you
吗？
hear me? Can you hear me?
Yes.
李雷教授在吗？
No.
Is Professor Li Lei here? Can you hear me?
喂
李雷教授，
喂，听得
李雷
到吗？
教授他在线上，可是不晓得人在不在。
So, Professor Li Lei is asking, can Willie hear him?
李教授在吗？
对啊，我
Willie is asking, are you there?
如果李教授不在的话，其实他已经把他的问题也已经先发给我们了。
Willie thought that.
好，李教授。
Okay, so Professor Lee is here. So please open your mic. Are you on the plane now?
对，现在
Yes, indeed. So can you all hear me? So are you on a plane?
李教授的
可能没有
工作
办法
非常杰出。
听到这个您的这个发音。
So Willie is saying that he couldn't hear from Professor Lee. So Willie will just ask the question on behalf of Professor Lee. And the question is, Caprini score on COVID used +2, +3, +5 for various degrees of clinical severity and presentation. Why was the sequence of number used? What versus +1, +2, +4, etc.? This is the question.
Thank you very much for your excellent question. And in my zeal to provide the maximum protection to these patients who are so riddled with thrombosis, I put those numbers out, and Professor Lobostov in Russia was kind enough to do a study on those and compare it to the traditional Caprini score. And we also did the same thing in our institution. And so the reason we picked those numbers was due to the high incidence of thrombosis in this disease. I have to look back and say that after we looked at the first 6 months of data, that was a mistake. And I think that's important to acknowledge, that it didn't work any better than the standard Caprini score, because we found if we just used 1 point for infection that's in the standard score and 3 points for positive D-dimer that's in the standard score, we achieved the same functional result. So it happens when you go through life and you do things, and especially I've been known to take a lot of chances and to put things out there and see what happens, but I'm also the first to acknowledge when I do something that I don't think is exactly correct, and we need to go back to the original and not do the modified as I suggested. So that's new information. I'll have a new video on that. My last video of the year will be COVID-19 summing up this year, and I will put that in there and some of the data in there from our study.
好的，非常谢谢 Caprini 教授的这个答案。这个也谢谢我们李雷教授。
for your answer. We thank Professor Li Lei for participating in our webinar, although he is about to fly.
是观众的一个
Now we will invite the audience to ask questions.
一个问题呢，是来自埃及的瓦塞拉，他
The most wanted question is from Egypt.
打的这个问题，那我就试
The
着
question is typed in English. I try to interpret into Chinese.
尊敬的 Caprini 教授，
Thank you,
就像您所
Professor
说的，
Caprini.
抗凝
Just as you said,
在
anticoagulation therapy
病毒 VTE 的病患中，
plays a very important role in COVID-19 VTE patient.
我
My
们需
question
要
is,
用多久的抗凝方法
how long shall we conduct antithrombotic
这个问题？
therapy so as to prevent bleeding, especially in weak patients? Thank you. Caprini, please.
Thank you very much. It's a very excellent and complicated question. To begin with, patients need protection from venous thromboembolism for the entire period of time that they are at risk. And one of the problems that I've had all along with even some of the clinical studies is that they don't emphasize enough that you have to protect the patient for as long as they're at risk. And with the COVID patients, that may mean long after hospitalization. For example, if a COVID patient goes home and has an elevated D-dimer, you can't stop the anticoagulation safely, in my view. That needs to be continued until that D-dimer is back to normal. And I think that's a very important consideration. The other thing that has to be looked at is the bleeding side of the equation. And we have to make sure that we're looking at real bleeding events. And again, as I said before, I think it's very important in the weak patient. And I think by the weak patient, you're also meeting the patient that might have some renal impairment, some organ insufficiency, or maybe at a higher risk to bleed because of a history of gastrointestinal bleeding. And that's where it's very important to employ my secret weapon, my intravenous heparin drip, because in that way you can provide some protection to the patient, but at the same time, you can protect that patient if it develops untoward events. And of course, as I said also before, is that sometimes when the patients go home, they don't necessarily need to take low molecular weight heparin. You can use one of the oral anticoagulants if that will give a greater compliance on the standpoint of the patient. I don't know if that answers your question.
好，谢谢我们 Caprini 教授的这个完美的一个回答。
Thank you, Dr. Caprini, for your wonderful answer.
中国的一位权威。
Now I would like to give the floor to a very authoritative professor in China. He's from Beijing Anzhen Hospital, the chairman of China Vascular Surgery Association, Professor Chen Zhong.
陈主任，欢迎您。
Professor Chen, welcome on board. Please share your screen.
好，我现在分享一下我的 PPT。
Now let me share my PPT.
能看到吧？
Can you see it?
看得到，谢谢陈主任。
好的。非常感谢季教授的介绍。
I thank Professor Ji for your introduction.
从事静脉疾病治疗的各位同道，大家好。
Welcome on board, all the vascular surgeons around the world, and all who are engaged in venous diseases. Today, I will share with you China's guideline on CVD management. In terms of epidemiology of incidence, compared with the rest of the world, China is more or less the same picture. In terms of CVD or VTE, China has similar incidence compared with the rest of the world. CVD has different incidence rate across different continents, but the incidence rate is always high. North Asia region, more than 50% of people have CVD. A standardized treatment guideline for CVD is very important. To make this guideline, we collected literature which totaled 132 articles in China since 1978. More recently, we found more articles published in this field than before. In 2014, Chinese Society of Vascular Surgery Committee issued the expert consensus of CVD. In 2019, the Vascular Surgery Committee of China Medical Association issued the CVD guideline. The guideline was a joint effort of Professor Wang Zhibing, myself, and many other experts. And Professor Wang Zhibing and I were served as leaders. Of course, there are differences or some gaps between the Chinese guideline and the international guideline, but the 2019 guideline is an important progress compared with the 2014 Chinese consensus. It was prepared by Chinese Medical Association, China Medical Doctors Association, working with a large amount of Chinese medical associations. It incorporated opinions from top experts and also evidence-based data from home and abroad. We referenced 50 articles overseas, especially ESVS CVD guideline. Right now, China has vascular surgery department in 1,000 hospitals, and there are more than 10,000 vascular surgeons. There are 132 member hospitals of CMDA CAVS. We hope our guidelines can be used by more grassroots hospitals and used by more doctors. Vascular surgery department grew very rapidly, especially in Beijing. Now Beijing has 48 vascular surgery departments compared with 21, and vascular surgeons in Beijing grew from 203 to 443. That rise shows the robust development of vascular surgery departments across the nation. This version of guideline introduces epidemiology, pathogenesis, diagnosis, and treatment. Added chapters include congenital venous malformations, post-thrombotic syndromes, and lower venous ulceration. These three were absent in the previous expert consensus, and in every part we added very detailed recommended opinions. We provide very detailed recommendations in terms of CEAP classification and application of VCSS, application of compression therapy, standardized sclerotherapy, treatment for perforating veins, repair suggestion for deep vein, valve, and endovenous therapy, chronic venous obstruction treatment, VMS specific treatment strategy, PTS treatment strategy, and prevention strategy, and venous ulceration suggestion were also provided in great detail. We provide standardized opinions for treatment details. So we have expanded the scope of venous diseases. In terms of key questions, we focused on CEAP and VCSS. Previously, we used a Chinese version of simplified CEAP, but in this particular version, it is completely aligned with the rest of the world, using complete CEAP classification and VCSS system. The goal is to enable China to be at par with rest of the world, learn from literature from rest of the world, and communicate with our international colleagues. With this promotion, I'm confident that we are able to promote standardized prevention, diagnosis, and treatment of venous diseases across the nation. We provide detailed description over compression therapy. We provide different guidelines for different situations, and also provided very detailed guidelines for intermittent pneumatic therapy. For sclerotherapy, POL and STS are the main scleral agents. In terms of their usage, interval, dosage, and the application details of each scleral agents were provided. This was based in 2016 guiding opinion under the name of the China experts. In sclerotherapy, we now use the classification to provide therapy on higher levels like C4 and above cases. Apart from conducting open surgery, sclerotherapy can be combined. So in this way, the sclerotherapy is no more conducted strictly according to the classification. In terms of surgery, we provided individual treatment recommendation. In terms of invasive therapy, we provide individual therapy. In these three chapters, congenital venous malformations, PTS, and venous ulceration, we provided very detailed recommendation. Now, all the treatment for congenital is symptomatic treatment. So we provide treatment recommendation based on specific methods and classification. For PTS, if involving iliac vein or vena cava obstruction, we recommend open surgery cautiously. For venous ulceration, we focus on treating perforating veins and its benefit of healing the venous ulceration. This particular version is more practical, more granular. Therefore, it is a progress compared with the previous version. But compared with ES, we still have a gap. We have no suggestion for application of equipment. For different levels of hospitals, there is always differences of equipment used, or there is no complete set of equipment. So we haven't yet provided a suggestion. In terms of management for clinical research, we haven't provided much opinions. We have not mentioned evidence level. Although we provided evidence and recommendations, but in terms of differences in evidence level, we have not done a good job, especially in terms of imaging and diagnosis. We don't provide evidence level yet. However, compared with the 2014 expert consensus, the 2019 guideline is a great progress, which focuses CEAP classification and VCSS scores. It provided detailed recommendations, including explaining each treatment for CVD, and provide individualized treatment for sclerotherapy and surgery, and for congenital venous malformations, PTS, and venous ulceration, we provided introduction and standard therapy strategy. I believe this is a strength of the guideline. In the future, as China accumulates more experiences and more global evidence available, China Guideline will make further progress. China Guideline will provide guidance for hospitals of different levels. Due to high incidence of CVD, Chinese CVD guideline influence a large population. It's necessary to provide updates timely based on new evidence. Because of time limit, I couldn't give you a very detailed explanation. I just touched the big picture. I hope in the future I will have opportunity to converse with world-leading experts and sharing our ideas. We thank VWing for providing such a platform. Thank you very much.
Well, thank you, Professor Chen, for your excellent presentation about the venous disease guidelines in China. Now we'd like to open the floor to the experts for questions. One from international, one from China. The first expert is from South Korea, the Samsung Medical Center, who's the director of vascular surgery, and also who's the vice president of the Asia part of the International Venous Society. Professor Dong, so please ask your question.
It's my turn.
是金教授，您请。
Can I give a comment?
Yes, please.
可以，您请。
Sure, please.
Okay. I'm Dong Kim from Korea. First of all, I am very happy to join today's webinar. Also, happy to see many of colleagues from China, Dr. Shenming Wang, hi, Dr. Jing Song, Dr. Li, and Dr. Chunga from Peru, and my friend Sergio and Oscar. Anyway, thanks Dr. Zhong Chang for a very nice presentation. From your slide written in English, I will give some comments and one question. As we know well, the pathophysiology of venous disease is similar in all of the world, but the epidemiology is different according to each country's condition, such as economy, lifestyle, and pattern of diet. So when we develop the guideline on chronic venous disease, the main concept will be the same in the world. So my question is, are there any major different points, or are there any special things in Chinese guideline compared to the other countries' guidelines? Again, thanks and congratulations and wonderful organization for today's webinar. Thanks.
Well, thank you, Dr. Kim, for your question. It's a very well put question. It's fair to say that indeed the China's situation, when compared with those countries in Asia and globally, is quite different. For example, the attitudes of the patients towards the treatment of disease is highly different. Take the varicose veins as an example. Many of the patients, towards the preliminary indication of the varicose veins of patients, they are not willing to treat them through a very positive intervention, for example, using the sclerotherapy, because they wouldn't take it as a very severe disease, just a change on the skin. So they would take sclerotherapy as a very aggressive therapy. For the chronic valvular malformation or the problems, some of that will lead to the edema, so they wouldn't choose to face that using a very aggressive or positive intervention to treat them. So the very attitude from the patients in China, we will adapt to their attitude. We will shift our focus on to a more severe patients for treatment. However, recent years, as the attitudes of the Chinese patients have been shifted towards a better and healthier lifestyle, and they've raised their awareness towards the disease treatment, there is an increasing number of the population that has started to have a higher requirement in that regard. Therefore, on top of what we have built upon in the past, apart from our focus on the C4 and above severity level, we are now also focusing on the treatment towards the C2 or C3 patients. We will start our treatment on them as well. So that has been shown on the Chinese guidelines. Initially, we only focused on the very severe patients, but now it has been extended to the less severe patients. But currently, I think when compared with the good ESVS guidelines or other guidelines, I believe the biggest difference between them is that the level of the evidence-based medicine evidences is not that enough, at least because that our clinical data from China's practices is not enough, and we lag behind in that regard. However, with an increasing of the exchanges at the international level among all the practitioners, we will definitely borrow on the best practices from other countries. So we believe that the data from other evidence-based medicine practices will be borrowed by us as well. And with an increasing of the exchanges, we will promote the development in the chronic venous disease. So I don't know whether I've answered your question. If there's anything unsaid or untackled, please contact me later after the session. Thank you again for your question. Thank you, Professor Chen. And our next question will be asked by one of our Chinese experts from Shanghai Hospital of China, the Deputy Director of the Vascular Surgery, Professor Lu Qingshan. Professor Lu, please open your mic. It's already open. So please ask your question. Well, thank you, Professor Qi, and thank you, the organizer, for having this event. And thank you, Professor Chen, for representing China, sharing Chinese guidelines. I've got a question. We know that following China's economic expansion, most Chinese citizens are now covered by public health insurance. Especially in the last 5 years, we have seen such movement. So in that context, how will this impact the Chinese guideline? And how will the implementation of guidelines throughout the hospital systems be affected? So those are the two questions that I'd like to ask you with regard to the Chinese guidelines. Thank you, Professor Chen. Thank you, Professor Liu, for your question. Actually, your question is quite similar to that posed by Dr. Kim. There are some common grounds between your questions. In China, now most of our citizens has been covered by the public health insurance, as you put. Nearly every one of the Chinese people can get the services of the basic public health insurance. That has tackled a lot of the problems that has emerged due to the lack of the public health insurance. So it will encourage patients to get treatment. For example, some less severe patients who are living in very remote areas or in rural areas, they didn't enjoy the public health insurance in the past. So when they faced a very light symptoms, they would just use a conservative treatment instead of a more active intervention. With the public health insurance covered and fully established, we believe that there will be more patients or citizens to move their treatment window more in advance. So it is because of that change, the coverage of our guidelines will be more extensive for more primary healthcare organizations. We believe that will serve as a very good guidance for their practices. For the chronic venous diseases, we believe that the treatment is very simple and the risk is very low. So it's got more hands-on practices or experiences. So maybe in the future, at all levels, the medical institutions, especially those at the primary level, our guideline will definitely serve as a very good guidance for them. That is why we have made our guideline as detailed as possible, especially with regard to the recommendations of the treatment methods. It is built upon that consideration that we want to benefit as many of the patients as possible, as many of the primary hospitals as possible. So thank you for your question. Very good question. Thank you, Mr. Chen. Professor Chen has shared with us some of the insights of the guidelines, and which has been widely responded through our audiences. One from Mexico, a very famous surgeon who are very keen to get the guidelines, and Mr. Chen is now talking to him. Now we come to the audience question. We've got an English question, and I like to translate it into Chinese. It's about the superficial venous, or we call it the saphenous veins. And its impact on the quality of the lifestyle. So the question is, do you have any description with regard to that in the guideline?
What do you mean by occlusion? Do you mean using ablation or using laser to achieve occlusion? Well, in mainland China, it is very popular to use minimally invasive technology. We use laser ablation and other traditional treatments. Apart from that, a large number of hospitals, while reserving the open surgery, still adopt minimal invasive and multi-point accession. In terms of occlusion rate, a lot of patients pay attention to occlusion rate. For example, what kind of frequency we use, what kind of laser we use. They have certain degree of non-complete occlusion leading to complications. Therefore, we need to inform them thoroughly that there could be 10 to 15% of patients that might have incomplete occlusion. So they will choose between open surgery or minimally invasive surgery. So a lot of hospitals have emphasized the problem of occlusion rate. We hope with more accumulation of clinical experience, we will able to enhance the occlusion rate in the future. We thank Professor Chen for your answer. Now we come to the third speaker of the day, Professor Li Yiqing from Wuhan Union Hospital, affiliated to Huazhong University of Science and Technology from Wuhan. Now, Professor Li, please share your screen. Yeah, we can see. Professor Wang Shen Lin, Professor Ji, Professor Wang Jingsong, Professor Caprini, dear Chair, colleagues from home and abroad. Today, I will share with you COVID-19 antithrombotic therapy and research. Up until now, from the outbreak of the pandemic, a year has passed, but the situation is still very dire. By December 15, 2020, the globally confirmed cases reached 70 million and death rate reached 1.6 million. Although the control situation globally and in China is stabilizing, we know that in winter time, we should double our vigilance against the second wave of the coronavirus pandemic. We need to fight back together. I come from the first epicenter of the pandemic. On behalf of Wuhan vascular surgeons, I thank all the colleagues across the nation, especially colleagues of vascular surgery from around China, for your contribution and sacrifice for Wuhan. Without you, Hubei would not have prevailed. But the pandemic is far from over. Taking stock of the past will enable us to be successful in the future. This is a date to remember. On January 23rd, 2020, Wuhan was locked down. Wuhan has more than 10 million population. I don't want to see history to be played again. Vascular surgeons shoulder a large amount of anti-pandemic work. A lot of my colleagues were transferred to makeshift hospitals, fever clinics, and isolated wards. We have more than 20 doctors and 50 nurses transferred to the front line. At the beginning of the pandemic, we had a lot of thought about those infected cases. We had a joint consultation. This is a severe infectious patient. We found some very high D-dimer, much higher than the normal upper level. But we cannot diagnose VTE. Is anticoagulation needed for this patient? My opinion and suggestion is to provide antithrombotic therapy. With Clexane, his D-dimer and other indicators went down, and his clinical symptoms and conditions have lessened. Questions. This patient's D dimer is abnormal. Does it indicate VTE? If so, what are the reasons and mechanisms? This patient has not been diagnosed with VTE. Is anticoagulation necessary? Various biochemical indicators and clinical manifestations have improved. Does it mean anticoagulation is effective? It's difficult to answer these questions at the time. We need to explore further, given this sudden outbreak. As the pandemic continued to develop, we understand the close relations between COVID and venous thrombosis and the importance of anticoagulation, as evidenced by the release of multiple clinical studies and guidelines. This is an article from Circulation. Incidence of deep venous thrombosis in critically ill patients of COVID is as high as 85%. Widespread formation of deep venous thrombosis may be an important cause of death. In the dead COVID patients, 1/3 of patients died of PE. Both famous agencies from China and abroad issued guidelines, including China Medical Journal and the US similar societies, NIH and CHEST, all provided guidelines. These guidelines have a lot of similarities. For COVID, we need to evaluate the risk of VTE. When closely monitoring bleeding risk, we need to conduct cautiously the anticoagulation therapy. The multiple guidelines provided good scientific guidance for VTE treatment, but we need to study some unknown factors. This is a study done by my hospital. This is not a very deep study, nor very scientific, but at that time, that is as much as we can do. We recruited 124 critically ill COVID patients for VTE and anticoagulation research. We found that their death rate and transfer to ICU are significantly higher, while their discharge rate lower. We also found that the VTE incidence has gender difference. Multivariate regression analysis suggests that high age and gender are risk factors for VTE. During our study, we found that after anticoagulation therapy, the lymphocyte count increased. For COVID-19 combined with VTE patients, the result shows that anticoagulation treatment lead to higher lymphocyte count. That shows that higher lymphocyte count can accelerate recovery, but we are studying the mechanism behind it. To study gender difference, we recruited 121 COVID patients into 4 groups, as shown on the picture. This is our result. We found for the first time that anticoagulation therapy had a gender difference. After receiving anticoagulation for males, their neutrophil lymphocyte ratio appears significantly higher than in female patients, indicating higher inflammatory response in males and better recovery in females. And the study found consistent results with overseas studies that male COVID-19 mortality is higher than females. We suggest male COVID with DVT should prolong and intensify in-hospital and post-discharge anticoagulation therapy. However, specific reasons and mechanisms for gender difference in COVID is being further studied. It could be social behavior, it could be biological. A possible explanation is sex hormones are involved in immune system's inflammatory response. And plasma concentration of ACE2 in men are higher than women, and ACE2 gene is located on the X chromosome. And some other differences. Summary: VTE has a high incidence in COVID. COVID-19 combined with VTE is an important cause of death or poor prognosis. Anticoagulation therapy can effectively improve prognosis of COVID, reduce mortality, and be mindful of gender difference in anticoagulation therapy. The outbreak brought us too much pain and too much unknown. And in the area of anticoagulation, further study is needed. Thank you.
Thank you, Professor Li, for your excellent speech. Now it's the expert questioning session. The first expert is from Uruguay Phlebology Society, Professor Pergo. So, Professor Pergo, please ask your question.
Thank you, Sergio and Oscar, for this big opportunity. And I want, and I want to congratulate Dr. Li for this excellent presentation and a very clear. In our institution, we think that the procoagulant state that we see in patients with COVID-19 could include a catastrophic antiphospholipid syndrome. No, it's an antiphospholipid syndrome. The patient could include exactly. This condition may explain the more adverse prognosis for this patient. I want to ask Professor Li if in this hypothesis, do COVID-19 patients develop antiphospholipid antibody that could explain their prothrombotic risk? First. Second, if patients develop antiphospholipid antibody, is there a correlation between the severity of the disease and the title of antibody isotype? And finally, is the development of prothrombotic event after leaving hospital due to the persistence of these antibodies? Could this determine the duration of thromboprophylaxis? Thank you very much for your attention and for your kind response. Thank you.
Thank you very much. Well, Professor Li, in the interest of time, you only need to answer the very first question. Thank you. Thank you, Professor Ji. Thank you so much for your question. So for COVID-19 patients, thrombosis risk has been testified by a number of studies, unless our team didn't have a research on the changes or impacts of the APL antibody on the thrombosis of the COVID-19 patients. Nor do we have any explanations to testify that if we've got any interpretation of that. But what we are sure is that the APL antibody and its relationship with the thrombosis has been testified. So the APL antibody patient tend to be the patients with high risk of thrombosis. Thank you. Thank you, Professor Li, for your answer. In the interest of time,
现在我们就到中国的专家的提问。
we would like to hand it over to Chinese expert, Professor Dai Xiangcheng, the director of the vascular surgery from Tianjin Main Hospital of China. He has just texted me by saying that he had to go offline because he had to attend another meeting as the keynote speaker. So he has handed over the question to me. The question goes that since the agenda has become a high-level factor for the VTE for the COVID-19 patients, so we don't recommend the anticoagulation to the treatment. If it's male, shall we use the anticoagulation to the low-level severity male patients? Well, for the gender differences, for the reasons and mechanism behind that differences, we are now researching on that topic. So whether shall we increase the level of anticoagulation is, first of all, we should have a Caprini score towards the risk assessment. So if the score is very high, by which I mean that the risk is higher, then the male patient should receive anticoagulation treatment after the discharge. If the male patient, if we want to, we need to strengthen the dosage of the anticoagulation of the male patients. Thank you, Professor Li, for your answering. And now, we'd like to hand it over to the audience question. We've got 3 questions in Spanish from South America, so I couldn't possibly translate. So, Sergio, could you please translate 1 out of the 3 questions?
Sure. So, we have a question.
It seems a question about the prevention of the coagulation.
Yes, the most liked one is from Dr. Salas. And the question is, D-dimer level can remain high for quite a long time. So for how long should we keep thromboprophylaxis? So keeping the thromboprophylaxis and D-dimer, really.
Thank you for your question. The dimer, we need to study the pathogenesis, control the diet. We need to make D-dimer go back to normal. When D-dimer go back to normal, we would stop anticoagulation or extend prophylaxis according to D-dimer. Thank you. Now we will share the abstract. BWIN is an international organization. Hope young doctors, including young doctors from China, will take advantage of the platform to share and publish their articles abroad. Today, we are very pleased to have chosen Dr. Song Xitao from Peking Union Medical College Hospital. Today, he will talk about major angles along the pathway of iliac veins that might be involved in endogenous interventions. Can you see it? Yeah, we can see it. Yeah, we are ready. Thank you, Professor Ji, for your introduction. Dear Chair, I'm Song Xitao from Peking Union Medical College Hospital. Today, I will talk about major angles. We know that stenting has become a common method for treating iliovaco-occlusive diseases, which include standard and venous stents. Standard stents have lower primary rate than venous stent. That could be specific anatomic reasons, like compression and kilking. So kilking and straightening may relate to some after problems. So from the PS view, we know that it looks like a straight line, but actually it is tortuous. So we have a few questions. Then we recruited 50 patients without venous diseases, and we used computer software to depict their angles. Then we use the software and manual adjustment to establish the central line. And then we make a tangent line to calculate the iliac vein. We found that the left iliac vein has 2 angles, the right iliac has 2 angles, so left is different from right. We can see the angle is about 150, and this angle beta is actually involving the pelvic. This is sharper, and there's difference between left and right. The left side is sharper, less 10 degrees less. Now you can see there could be 20 degrees in difference. There are 3 different types. The angle Y is in inugo region. Symmetric between L and R side might be changing as the movement. We need to study angle beta. It could be predicted by the angle between the fixed vertebra and inlet plane of the pelvis, and it could change with age. The confluence angle of the left and right common iliac veins, the right-hand side is flat and smoother. So when we choose access point, we could choose right side. The right side is safer and easier. And after implanting the stent, we should avoid deploying the stent near the angle apex. An injury could be caused by straightening. If we need to release the stent, there should be enough buffer area so as to prevent kinking. We need to estimate length of lesion and stents needed. We need to consider angles to prevent stent tracking or contraction. We need to consider the angles. If there's not enough angles, there could be acute thrombosis formed and treatment failure. We need to consider shortening of stents. And we know that the hip may change consider compression by the bones, potential implications. Understanding the angles of iliac vein is very useful. It can help us selecting access, avoid strengthening, planning stent landing and overlapping, estimate and pre-compensate stent length to diminish shortening, and avoid trap of endoluminal instruments. And it's helpful for us to design specific venous stent. Thank you, Song. Now please stop sharing your PPT. Thank you. Now we come to expert questions. The first expert is from Peru, Peruvian Society of Phlebology, Professor Chunga. Your question, please. Professor Chunga.
I would like to thank Dr. Wang, Dr. Giannesini, and Professor Bottini for the invitation. Dear Dr. Song, it has been a pleasure to hear your excellent presentation.
Can you please go to the English channel? Can you please go to the English channel, Dr. Chunga?
Interpretation? Okay. Now? It's good? Okay. Okay, again. First of all, I'd like to thank Dr. Wang, Dr. Giannesini, and Professor Bottini for the invitation. Dear Dr. Song, it has been a pleasure to hear your excellent presentation. It seems to me that this work will make a positive impact in the treatment of iliac vein disease. My question to you is, after your investigation, do you consider that the value of the angles that you have presented would vary greatly according to the age, especially in the elderly, and race of the patients with iliac vein diseases? Again, thank you very much for the invitation and congratulations.
Thank you, Professor Chunga, for your question. Good question indeed. In my study, we found the angle of iliac vein is flatter in younger people, but more tortuous in older people. So angle is closely related to age. That could be muscle, it could be soft tissue. As we age, the tissue and soft muscle will change. So we have two assumptions. For elderly patient, we need to pay more attention to angles because angles would lead to procedure-related complications. For younger people, although they are straighter, but we need to consider as these patients become older, they may have future problems and they have distant complications. I mainly study Chinese. They are of Han ethnicity. But through literature suggested that different races have different pelvic structure. That would also give rise to different angles of iliac vein. That requires different countries to conduct race-specific study. Now the last speaker of the day is from Shanghai Zhongshan Hospital, Yue Jianing. Thank you, Professor Ji. First, we thank Vi Wing for your invitation, and we thank Professor Wang Jingsung and Giannesini for organizing this event. I just listened to Dr. Song's presentation. Very interesting. When we treat iliac vein, this is a question we always overlook. But after your presentation about the angles of iliac vein, and your wonderful overview and your research, I would like to give you a very short question. When we release the stent, we emphasize radial support, but we seldom consider the conformability of stent. In the future, we need to pay more attention to conformability. Radial first and conform and support. When we address it from an engineering point of view, it seems that it is a paradox. It's a dilemma. I think Abbott's stand can balance the two. But in Venus, in distant and proximal, when there's different radius, especially in those cone structure, it seems that it is less fit. Could Dr. Wang predict that in developing Venus stent, what are the key considerations for R&D? And do you think any existing choices and products can address the conformability issue? Thank you, Yue, for your very difficult question. I'm a young doctor. I have limited experiences in venous intervention, so I will try my best to answer your question. In your presentation, you mentioned different sides of the venous have different requirements for conformability. For proximal side, when you design the stent, you need higher radial support. But for other part, you need more conformability. The commonly used stents, I hope, I need a strong support at proximal side using wall stent. And the other part we use vena stent, which has better conformability. In terms of future stent design, we hope at different sections, we hope the stents can reflect different compression, different anatomical needs of the body. Thank you. Now we are very pleased on behalf of the Wing Foundation to provide you a summary. Professor Caprini last a presentation on COVID-19 thrombosis. Caprini score is a dynamic measure used by more than 5 million patients and 200 studies. Professor Caprini also explained the formation of cytokine formation, and factor 12 is very important. During COVID-19 thrombosis, that can give rise to thrombosis. Anticoagulation is not the only answer. There are other aspects like anti-inflammation, anti-kinin methods should be included in the equation. If Caprini score is more than 8, you need to double the pharmaceutical dose, but it is not verified clinically. This is purely recommendation. After discharge, these patients have high VTE risk. They need long-term prophylaxis. In Professor Chen Zheng's presentation about China's CVD guideline, you described China's CVD incidence is similar to the West. China's vascular surgery department. Now China boasts the highest number of departments across the world. China has more than 10,000 vascular surgeons. From 2014 to 2019, the latest China CVD guideline was released. Apart from epidemiology, pathogenesis, diagnosis and treatment, and 3 chapters including congenital malformation, venous ulcer, and PTS were added. Mr. Chen also talked about the strengths of Chinese guideline. It's easier to apply clinically, but any guideline has room for improvement. They need to provide imaging suggestion and evidence grade. Professor Li Yiqing talked about China experience in anticoagulation therapy. You started with a case, fever, dyspnea for 1 week. And he has 85% incidence rate for VTE. According to CHEST guidelines, the importance of prophylaxis for VTE. In Wuhan, we found very interesting study about gender difference. Male has different inflammatory response. Male have higher ACE2 receptors, and females have better immunology. That's similar to the rest of the world. Males have higher inflammatory rate and higher mortality rate. A wonderful abstract about left angles. There are 3 angles on the left and 2 angles on the right. The right is safer and easier. Avoid traps of space and pay attention to stand design. Now let's give the floor to Professor Giacini. Professor Giacini, please.
I'd like just to deeply thank all the giants who have walked today on this path from the great Chinese Venus wall, like we are usually saying with these webinars. And of course, the road is toward the Expo in Dubai, as I was saying, so please advance, Willie, so that we can celebrate the last step we had on this educational walk that indeed was related to the Achieve webinars, and we had the honor also there of having Professor Caprini and many other colleagues and friends who we deeply thank. And we tried with this initiative to engage also the audience, so please advance, Willie. And indeed, with this tough COVID time, sometimes it's difficult to engage the audience to come live and achieve the stage, but in this case it was a successful experience because we had a selection of evidence-based comments, and today we celebrate with the Chinese colleagues and friends the identification of the winner. Please advance, Willie, that indeed is from Spain, Dr. Fraias Vargas, in a representation of the general practitioners. So it's a nice opportunity to teamwork between our experts and the experts of general medicine. With this, I deeply thank once again all the Chinese and the international friends who have gathered today, and I congratulate all the faculty that has been truly stellar as always.
Let's invite Professor Bottini. Professor Bottini, please.
Okay. Well, good morning, good evening, good afternoon, good night, all. Thank you. Excellent presentation, excellent webinar, Willie.
Lastly, let's provide Professor Wang Shenming to give us some conclusive remarks. Professor Wang, please. Professor Wang? Hello? Professor Wang? Thank you, Professor Ji, for your invitation. Well, this summary should be done by Professor Chen Zheng, but he's very busy right now. So let me give you a summary. Just now, Professor Ji already gave us a wonderful summary on behalf of China Flambology Society. I thank Professor Giacini, Bottini, Sergio, and Professor Ji and VWin Foundation for organizing this webinar. The 3 speakers and 1 abstract presentation will provide positive impact on China's vascular surgery development. We love this webinar. We have already gone 5, and there will be 1 more in January. We hope more doctors will participate in these webinars. Thank you. Thank you all. Thank you, President Wang. VWin is an international academic society on venous lymphatic We provide free educational resources
你们可以尽量使
provided
用。
to experts around the world free of charge. And we thank
Sigma.
our sponsors, Alfred
BD
Sigma,
麦迪
Meisu, BD, Medi, Felix,
参加的
and
所有演讲者，
Sigvaris Group.
我们
We thank
明
all the
年
participants.
再见。
Let's see
谢
each
谢大
other on January the 16th. I wish you a wonderful holiday season. Happy New Year. Thank you and goodbye.
谢谢，谢谢。
谢谢大家。
Goodbye. Bye
See you.
bye.
Bye.
See you in January. Thank you all. Thank you, Professor Lee. Bye.
老师，谢谢陆老师，谢谢。
Bye, everybody.
主任已经下线了，所以谢谢。
Happy New Year.
好，谢谢。
And thank Professor Chen Zhou. Bye. See you next time. Until next time. Bye bye.